Good morning, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Buprenorphine, an effective partial agonist medication for opioid use disorder. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Before we get started, let's go over a couple of technical details. Please note that as an attendee, you are in listen-only mode and will only be able to view your own name. If you have questions, please send them to the presenter and me, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Use the Q&A panel to send any questions as you may think of them. The presenter will answer questions today as we move through the presentation. Our audio is being broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now. These options are also posted in the chat panel. If you continue to experience a loss of audio through your own computer speakers, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio portion of the presentation and view it on screen to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FATA website within 5 business days. Also, a PDF version of this PowerPoint presentation will be emailed to participants within 5 business days. Approximately 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and also for persons credentialed through the Florida Certification Board. At the event's conclusion, the web browser will direct participants to an evaluation form on the FATA website. If you would like to receive continuing education credits or a certificate of attendance for this event, you must complete the evaluation. Be sure to include any Florida license number, if applicable, for reporting to CE Broker, along with the prefix for your license number. The certificate of attendance will be delivered to all attendees via your email address within 5 business days. Do note that WebEx monitors arrival and departure of attendees and provides us with a report upon completion of the event. This attendance log and the evaluation forms are used to validate the provision of contact hours or the certificates of attendance. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial credit. I'd like to introduce our presenter for today's webinar, Dr. David Gastfriend. An addiction psychiatrist, Dr. Gastfriend is scientific advisor at the Treatment Research Institute. At Harvard Medical School, he directed addiction research at Massachusetts General Hospital and was an investigator in the NIDA Cocaine Collaborative Study, NIAAA's Combined Study, and NIDA's Clinical Trials Network. As vice president at Alkermes, Inc., he directed publications on Vivitrol in clinical, criminal justice, and health economics research. Dr. Gastfriend's research on the American Society of Addiction Medicine criteria contributed to endorsement by most U.S. states, the VA, and Department of Defense. His 150 scientific publications include the ASAM criteria and addiction treatment matching. His continuum, the ASAM criteria decision engine, and ASAM's co-triage assessment tools are being adopted across the United States. Dr. Gastfriend's newest project is Dynamic Care Health, a nationally scalable technology platform for contingency management and predictive analytics for routine care. He has consulted to the governments of Belgium, China, Iceland, Israel, Norway, Russia, and the United States. And, of course, it's our pleasure to have Dr. Gastfriend join us today. And, Dr. Gastfriend, if you're ready, I'm going to turn control of the presentation over to you, and I'll also bring up your PowerPoint presentation.
Great. Thank you so much. It's a pleasure to be able to talk to everybody. And this is an important topic, so I'm glad that there's tremendous interest in what we're discussing today. The subject of buprenorphine is important because it's different from what came before it, and it's really proven conclusively to be effective as a partial agonist medication for opioid use disorder. So what do we mean by that, and why do we need to give this focus? I'm going to try and move the slides, but I'm not in possession of control yet. So,
Dr. Gastfriend, do you see your presentation on the screen?
Yes, I do.
Okay, and do click inside of the navigation window with your mouse first.
Very good. Thank you so much.
Of course, my pleasure.
So I want to make sure people understand that I have a number of disclosures to make. I have collaborated with industry on a number of different projects, and they include the topic of today. So I have been a consultant to Indivior, the manufacturer of buprenorphine, as well as to many other companies. We want to talk about the U.S. opioid crisis, which obviously is an epidemic these days. Society is very upset about this and is demanding that we use every tool in our toolkit, but that actually has not been the case. So we have to fix that. We have to change. FDA has approved buprenorphine, and it is safe and effective for treatment of opioid use disorder, and you'll see OUD in my slides. That's opioid use disorder. It is part of what we call medication-assisted treatment, or what I prefer, medication in addiction treatment, MAT. So you'll see that term abbreviated as well. And I'm going to review the chemistry and the pharmacology, why it's recommended for use. There are different formats of it, different formulations. There's some federal law involved in the use of buprenorphine. And there are also some important things to consider with regard to counseling and safety and both initiating treatment and concluding treatment. So when you finish this workshop, my hope is that you will be able to describe how buprenorphine works at the brain receptor and also its time course. You'll be able to implement a clinically effective treatment program with the combination of buprenorphine and psychosocial treatment or counseling. And you'll be able to manage the initiation, the stabilization, the maintenance, and the conclusion of buprenorphine in the appropriate patient populations. Now, the epidemic is affecting millions of people at this point. There are literally 400,000 people using heroin each month now. And overdose is now the leading cause in the U.S. of personal injury-related death. And the death rate has quadrupled in about 15 years or so. We actually have 1.5 times as many deaths from overdose in the U.S. than from motor vehicle accidents. And this rate is still rising. Heroin overdose deaths rose 26% in 2014 over the previous year, and fentanyl deaths doubled. So this is a huge problem in our society, and yet less than 10% of the patients who need treatment, who meet criteria, less than 10% are getting specialized care. And one of the reasons is it's a difficult disease. It's not a disease that affects only one organ, like diabetes affects the pancreas. It disrupts the brain in many ways and affects different regions. So we can think of the outer large region of the brain as an important consideration. That's the cortex. But the cortex has a specific role. Its role is in decision-making, thinking, and reasoning, and learning. And we want to address the problems that drug addiction causes in the cortex, and we do. The interventions we use are counseling and 12-step programs and monitoring with drug testing. But there's another region of the brain called the limbic region. And this limbic region is deeper. It's more primitive in that it evolved before the outer cortex thinking brain. But it has a very profound role on behavior because it affects basic drives. It experiences reward, euphoria, the pleasure of these substances of abuse. And if we don't stabilize that region, we don't get a foundation of stability on which to work on the cortex with our counseling. So it's like doing home construction on a foundation in quicksand. You can't rely on a strong structure if you start off that way. And the dropout rates in treatment programs that don't use medications teach us that. So what are the interventions that stabilize the limbic region, the drive region of the brain? Well, we have agonist medications and something called antagonist medications. And if it sounds to you like they might be the opposite of one another, you're exactly right. So what is opioid receptor activity? Well, these are little protein molecules on the surface of a nerve cell, a neuron. And on that surface, that membrane, we have these receptor molecules. Here you see them like little openings. And the endorphins are natural pain relief medications or molecules that are released in our brain. They're actually constructed by our own chemistry. And they get released from these little tubes or vesicles from one neuron across a layer of water or fluid, and they eventually reach another neuron downstream, and when they bind, they release or cause extra release of dopamine. And dopamine is the brain's own neurotransmitter that teaches us or signals us to eat when we're hungry, drink when we're thirsty, and it rewards survival behavior. So endorphins permit dopamine transmission. They're not the same as dopamine, they're a different molecule, but they permit dopamine transmission. What is an opioid agonist? Well, an opioid agonist, these are drugs like the analgesics, the painkillers, illegal opioids like heroin. Methadone is an opioid agonist. It actually works like heroin, but it's different. I'll tell you how. And it activates opioid receptors and promotes dopamine release. And the fast-acting ones like heroin, Percocet, Vicodin, all of those promote excessive dopamine release. So here we have a heroin-like molecule coming in to the brain through the bloodstream, and it hits an opioid receptor in the brain, or an endorphin receptor, if you want to call it that, and that triggers the release of dopamine. And that dopamine is very potent. It's a much more excessive amount of dopamine than our natural endorphins would ever cause to release. So that produces an excessive reward or a high, a euphoria. Now, what are partial agonists? So agonists are heroin-like drugs. What are partial agonists? Well, buprenorphine is the classic example, and it's similar to agonists, but there is a ceiling effect. It doesn't reach the full effect of a normal agonist. It achieves about half the effect, and I'll show you that shortly in another way. So this is the cell membrane, the edge of the nerve cell, and this little Y feature here on the end of this protein is receiving the agonist or can receive a blocker, an antagonist. If it receives an agonist, like heroin, then there is an effect. An agonist has an active site of similar shape to the brain's own natural molecule, and that binds to this Y receptor and produces the classic opioid effect. An antagonist just blocks that Y receptor. The antagonist has a similar shape, but it doesn't have the activity. So when it sits there, it not only prevents action of an opioid-like effect, but it actually blocks other opioids from getting to that receptor. So it's protective. And so we have agonists and antagonists. Now let's look at the effect on reward and brain dopamine activity. So an antagonist blocks the opioid-like effect in the brain when it hits the receptor. A full agonist, like methadone, has the full effect. The more you give, the higher the effect is. But it's a slow effect. It's not a quick onset like heroin. Heroin would be immediate, all the way up at the beginning here. And if you look at the partial agonist effect, you notice that it goes up for a while with increasing dose, and then it doesn't really get any higher. It doesn't produce any more euphoria or perception or feeling. And that's what we mean by a ceiling. It kind of plateaus out and doesn't get as high as the full agonist of methadone, whereas the antagonist doesn't produce any effect like this at all. So we have alternatives, and that fact, having alternatives, is very useful. Inside the brain, we can actually take pictures of where these drugs are binding. And a normal control patient who is given a drug that shows where the opioid binding regions are shows this sort of orange lighting up, this brighter lighting up area, yellowish maybe, in lots of different regions of the brain. A patient who's placed on methadone, which is a full agonist, is also showing plenty of that region lighting up, maybe less because there is some blockade now. The blockade is being done by methadone. But there's still some regions that are able to react to brain natural endorphins and allow the individual to feel comfortable, normal, because endorphins are responsible for comfort, well-being, and pain relief in the event you bruise yourself or have an injury. Buprenorphine binds to these same regions, and the more buprenorphine a person receives, this is 0 dose of buprenorphine or placebo, this is 2 milligrams, and this is 16 milligrams. As you get up, going up even to 32 milligrams of buprenorphine, you see that the blockade is pretty complete, 90-something% occupancy. And we actually don't want or need that. 16 milligrams will produce less than 100% occupancy, and that's actually good. 2 milligrams can actually allow a bit of occupancy, but also leave a lot of receptors available for the brain's natural endorphins. So one of the things that we have to think about with buprenorphine is what's the right dose for a given patient, because it can vary. Now, opioids are working at several important regions in the brain. In the limbic system, the substantia nigra and the ventral tegmental area, these neurons bind new opioid receptor ligands or binding agents. And when a drug like morphine or heroin binds to these regions, you decrease GABA's inhibition of dopamine neurons, which means dopamine neurons can release more dopamine. And that increases dopamine reward. And that leads to other changes throughout that reward system, that circuitry. When this happens again and again, we have recurrent withdrawal. And over time, what happens is that is punishing, that's uncomfortable, and it causes other regulatory changes. And it can, for instance, diminish the amount of reward one gets when one uses the same dose they started with. So you get less and less of a high over time. And these changes don't just go away the day that somebody stops using opioids. They actually persist for weeks or even months. And this is called negative reinforcement. And it's modulated or mediated by not just the endorphin system, but the dynorphin system. And it's also mediated by stress response. So the stress hormone axis, the hypothalamic pituitary adrenal axis, the HPA axis, has a major role in creating that perception of discomfort and stress and negative reinforcement, which makes the individual want to keep using. So this allows us to consider why people with addiction can't just give it up. Why can't they just choose a logical option of walking away from their drugs? And it has to do with the controls on the drive system. Addiction changes the brain circuitry. And so if you're not addicted, even if you use a Vicodin pill for pain, well, you get some degree of reward, and you remember, oh yeah, last time I took that Vicodin pill, it helped me with my pain. And that creates a certain desire to, use the Vicodin for pain control, but then you also have a healthy amount of impulse control. And if you're not addicted, your impulse control is able to balance the reward saliency and control your drive system so that you don't go into excessive or repetitive Vicodin use after your pain is ameliorated. But in the addicted brain, the reward saliency, the amount of effect or the influence of the drugs is exaggerated. And the memory for that is exaggerated. And in contrast, impulse control may be diminished. So now you don't have the same balance between impulse control and the pleasure or the euphoria or positive feelings. And therefore, the drive system is less equipped to hold back. And now you keep going forward in a loss of control process. So we have to address all of these processes, positive reinforcement, negative reinforcement, and the imbalance between the go and the no-go process, the reward and the drive system oversight. And we have several stages for these goals. So the first stage for anti-opioid pharmacotherapy is detox, or the modern term is withdrawal management. And unfortunately, we often stop at detox, which is not sufficient. It's not far enough. It's inadequate care. And both research and experience show that dropout rates are enormous if all we do is detox. Even if we follow it with counseling, without medication in opioid dependence, this is inadequate care. We need early recovery protection. That's when the risk for overdose is enormous. In prison release, when people are released having come in with an opioid-related offense and then they're discharged, we can see 12 to 100 times the death rate of the general population in people coming out of jail just within the first couple months, depending on which study. So that's an enormous amount of risk. And our first goal in early recovery protection should be harm reduction. And it's not just harm reduction from overdose and death. It's also from transmitted diseases like HIV and Hep C. So what else are we trying to deal with? We're trying to deal with addressing craving, stabilizing that urge or the impulse so that the patient is in counseling long enough for the counseling benefits to take hold. We're also wanting to see stress and the stress response normalize because opioid use disorder disrupts the ACTH, cortisol, or stress hormone system. And we need time for the brain and the body to relax that stress response. We're also looking for psychological extinction. When the individual has been using heroin for an extended period, they memorize all of the clues or the cues that signal that they could get score dope. And we need those sort of triggers to start to relax or fade before the patient is really going to be safe. Same thing with regard to the withdrawal symptoms. If somebody's been cycling into getting high and withdrawing all the time, they have to fade those reminders of that negative cue response of withdrawal. And so getting their blood pressure up, getting sweaty, getting tremulous muscles or muscle aches. Those things have to sort of fade in their memory a bit before they're really going to be safe. Otherwise, anytime they get into stress from any other reason besides drugs, they're going to be triggered to want to use heroin again. So there are a variety of biological stabilization phenomena that we need to achieve. We need to stabilize the eating cycle, the diurnal cycle, the day-night cycle or sleep cycle, sexual function, and a whole bunch of other biological functions need to be stabilized. But with all of these benefits of medication to address opioid use disorder, I want to make one thing really clear. None of these represents recovery. This is not the process of disease acceptance. It doesn't do anything for coping skills, learning, and it's not rehabilitation. So we talk about anti-opioid pharmacotherapy as a foundation upon which to start building recovery. Now, that's medication in general, but what about the specific buprenorphine category of partial agonist treatment? What's the rationale for that? So this is a type of, you could call it opioid substitution treatment or opioid maintenance treatment. And basically what it does is it stabilizes the brain circuitry in opioid use disorder. So the mu opioid receptors are occupied by this buprenorphine molecule, and this is a similar effect to all of the opioids, whether it's Vicodin, Percocet, all the way up to Dilaudid and fentanyl. And it's a long-acting medication. It can be given under the tongue. That's what sublingual means, under the tongue. Or it can be a film that's put under the tongue or on the side of the cheek, or a 6-month implant. And I'll explain those later and show some examples. It prevents withdrawal. It prevents craving. And I'll talk about this a little bit further. It extinguishes compulsive behavior. So that allows the extinction, the fading of these compulsive habits to start happening. It reduces the spread of HIV and Hep C. Criminal activity is reduced. It's safe for use in pregnant women. And it really is a bit of an advance over having only one choice, methadone. When all we had was methadone, okay, it was a good medicine. It is a good medicine still for some people, but this has some advances. And what are they? Well, less opioid effect than methadone. It doesn't reach the same peak if you keep going up on the dose. It sort of plateaus. It has a longer duration of effect than methadone. Methadone, I'll mention later, is about a 24-hour medicine, maybe 23 hours is a better way to think of it. This is more of a 36-hour medicine, buprenorphine. And reduced overdose risk. So because you can keep going up and then it plateaus, it doesn't give you the ever-growing effect. It reduces the risk of overdose compared to methadone. We have a history with methadone and a lot of experience with it. And it starts back in the 1960s, actually, with a very beneficial effect on stabilizing highly chaotic, chronic people with addiction. But there are some limitations. For one thing, it has some adverse effects. It has a lot of regulation controlling it and limiting access. There is diversion on the street, particularly since the AIDS epidemic, when harm reduction necessitated that clinics would provide methadone on demand, and it was less desirable to just cut people off if they weren't staying totally abstinent, and that did lead to some increase in diversion. Buprenorphine has been around as an idea since the 1970s, and it was not until the 2000s that the DATA Act, Drug Abuse Treatment Act, authorized its availability nationwide. And it became available around 2002, and it has progressed into different forms. In fact, now we even have a 6-month implant that's approved by the FDA called Buprenorphine. And I'll talk about that in some detail. The legal authorization for buprenorphine data allows it to be used in a provider's office. But you have to be registered and certified as a qualified prescriber to do this. There's an 8-hour course. It has to be applied for. You get a new DEA number for this purpose. And now the law allows for nurse practitioners and physician assistants to participate in prescribing buprenorphine through the law a year ago called CARA. So these two laws, DATA 2000, CARA in 2016, allow providers who have the eligibility for the waiver to get a registration number and be able to prescribe right out of their office. You don't need a methadone clinic license to use buprenorphine. You can have board certification of one kind or another in addiction treatment. You can be someone who's participated in an FDA trial or equivalent training if your state board permits, and nurse practitioners and physician assistants are eligible to prescribe too. One requirement, however, is that the prescriber of buprenorphine must be able to refer patients to counseling or psychiatric services. They have to have access established for those referrals. There's also a limit on the number of patients who can be treated with buprenorphine. In the first year of a waiver, you're limited to 30 patients at a time. After year one, you can go up to 100 patients at a time. To get up to 100 patients beyond 30, you have to have an extended waiver. So that's another application. Nurse practitioners and physician assistants need 24 hours of training, and it has to be an approved training. And they can go up to 30 patients in year one and then apply to increase to 100. Physicians actually can go up eventually to 275 patients, but NPs and PAs may not. And they have to make a request for patient increase to go up beyond 100. So those are the laws, and now let's look at the different types of medicine available. So methadone or buprenorphine are either oral with methadone or sublingual. And this is very beneficial compared to heroin because you're not using needles, and the onset of heroin, even intranasally, if it's snorted, is very quick. It's within minutes, and IV it's within seconds. It's the faster onset of the effect of heroin that makes it so addictive. If you slow that down to 30 to 60 minutes, which is what happens with methadone or buprenorphine, that slower route of administration makes it much less addictive. And it is a 30 to 60-minute onset for methadone or buprenorphine, lasting up to usually 23 hours with methadone or 36 hours with buprenorphine instead of the short-acting heroin. Again, short-acting means more addictive. And while heroin produces a marked euphoria, patients will not tell you that methadone or buprenorphine produces euphoria. They don't. They might perceive the onset of these medicines, especially as they start taking them, and it may be calming or comforting or even a little sedating if they're getting too much, but they don't get what they would consider any euphoria. Now, to go into a little bit more depth with the properties of buprenorphine, the effect of buprenorphine is modest. Even at a high dose, you're only getting about half of the mu agonist activity at the brain's endorphin receptor, only about half of the effect that methadone would give. And it also is good because it has a strong affinity or attachment to that receptor. So, for instance, it'll block all the opioids that are common street opioids, even Dilaudid, heroin, even fentanyl. So that's a very good thing. Now, you have to remember that that affinity, that linkage, is even stronger than naloxone. So if you do a naloxone challenge to see if the patient is completely off of buprenorphine, that's not necessarily going to be an effective test. We'll talk about that later, and when we go to the webinar on Vivitrol, we'll talk about that effect. Another important feature is the long half-life. I mentioned 36 hours of effect, and that means anti-craving effect for 36 hours, which is really great. However, because methadone might produce a very strong effect at a substantial dose, if you then give the patient suddenly buprenorphine, which only will give half of that effect, that's going to be like a half withdrawal state. So you can precipitate withdrawal, actually, if you give buprenorphine immediately when the patient's brain is responding to a full agonist. But the advantage of having a partial agonist is that you don't get as much respiratory depression or central nervous system, CNS depression. It has a sublingual route of administration, or there's some alternatives now. And it's been combined, a combo tablet has been created that puts the buprenorphine in with naloxone. And that means that if you have somebody who is coming off the street, has never used buprenorphine before, and they are a heroin addict, and you wait a day so they go into mild withdrawal, and then when you give them the buprenorphine, they will feel the onset of buprenorphine, even though it's only a 50% effect or so, and that will calm them out of their withdrawal, stabilize them from their withdrawal, and cut their craving. Now, if they were to crush that pill and inject it into their bloodstream, that amount of rapid onset buprenorphine could cause them a euphoria, and we don't want that to happen. So by putting naloxone, the blocker, an antagonist, into the Suboxone pill, what happens if they crush it and inject it is that the naloxone actually blocks them from either getting high, or if they've been on an opioid, it actually will put them into acute withdrawal. And so that discourages people from shooting up Suboxone. Whereas if it was buprenorphine alone, pure buprenorphine, and that's what Subutex is, Subutex, if you crush it and inject it, you will get high. So the combination of buprenorphine and naloxone has been a very beneficial aid to reducing abuse of buprenorphine. And that original product was called Suboxone. Here's the molecule of buprenorphine, and it looks a lot like the methadone molecule except for side chain differences. So when we have the patient coming in a day after they use, at least 12 hours after they use a quick-acting opioid like heroin, we start them in mild withdrawal. And if they're in mild withdrawal, then when they get the buprenorphine, the partial opioid effect of it will actually help them and bring them out of withdrawal and stabilize not just their withdrawal, but also their craving. So the fact that it's a slow onset opioid and has a long duration reduces reinforcement. And there's a lot of research showing this. And you can prescribe it daily, weekly, monthly. There are a lot of ways to prescribe it. It's really expanded access to care, but we need more sites in the country using it, more prescribers. And that's why, hopefully, you're in this project. I mentioned that it was out initially as Subutex, pure buprenorphine, but now it's more commonly used as Suboxone. And the amount of buprenorphine is 4 times the amount of naloxone in Suboxone. So if you're using 8 milligrams of Suboxone, it will actually have 2 milligrams of naloxone. It'll have 8 milligrams of buprenorphine and 2 milligrams of naloxone. And now there are other generic products. Subsolve is one, and there are film preparations. There's Suboxone film and Bunavail film. These are all approved and have different prices and slightly different features. In general, between an agonist like buprenorphine, which is a partial agonist, or an antagonist, an agonist, remember, is going to maintain the patient's physical dependence. And when they stop it, they will experience withdrawal. So that's a difference because antagonists like extended-release naltrexone or Vivitrol don't have that. An agonist, and even a partial agonist like buprenorphine, does maintain tolerance. So the patient is getting an opioid and doesn't lose their tolerance, but they lose their tolerance with an antagonist. Diversion is a potential risk with an agonist, and even with a partial agonist. That doesn't outweigh its benefit clinically, but it has to be attended to, and I'll talk more about diversion later. People can use narcotics or opioids on top of buprenorphine and on top of methadone, and if they use enough, they'll feel them. It's much harder to get through the blockade of an antagonist. And an agonist does have some effect or interaction with other drugs like benzodiazepines or sedatives, so we'll talk about that. On both of these medicines, agonists, partial agonists, or antagonists, these allow the extinction, the fading of heroin-reinforced behaviors. That means the underlying neurobiology can heal. So the duration of these is important. With agonists, and even buprenorphine, we talk about the duration as being very long-term, maybe even indefinite. And the reason is there is a withdrawal coming off of these. And even though, it'd be nice if there wasn't a withdrawal, and this is kind of a side effect, nevertheless, we have to pay attention to that because withdrawing from agonists produces the drive to reuse and relapse. That does not occur with an antagonist, so that means we don't have as clear a sense of how long patients should stay on antagonists. It may not be as long. But there are a lot of barriers, cultural and ideological barriers to agonist treatment. People have misconceptions. People will reject it on the grounds that there is a certain amount of abuse or diversion, even though the amount of benefit is far, far greater, far outweighs the diversion, and yet that will produce ideological rejection of buprenorphine and lead to professional and public opposition. But the most important thing to remember is that to not offer medication after a patient stops drug use really puts the patient at increased risk of overdose and death. A little further depth into these features, methadone, the full agonist, is a Schedule II drug. Buprenorphine, which is a partial agonist and therefore has some safety advantages, is a Schedule III drug according to the FDA. And naltrexone or Vivitrol has no scheduling at all. And that's because of the maintenance of physical dependence, the potential for diversion and abuse. Tolerance actually isn't necessarily a bad thing. It can be a good thing because that means if the patient goes off of buprenorphine and uses the same number of bags of heroin they used before, they may not be at risk of dying in an overdose, whereas if they did that with coming off of Vivitrol, and it's been enough weeks that all the Vivitrol is washed out of their brain, they could be at risk of overdose. Diversion issues I mentioned is more of an issue with methadone, but also with buprenorphine. You don't need any opioid detox with either methadone or buprenorphine. You do need a withdrawal state to begin with buprenorphine, unlike methadone. Both of them, upon discontinuation, provoke relapse because of the withdrawal. Both of them, you have to manage pain if the pain has new acute onset while they're on these. But you can manage pain. You can add a opioid analgesic painkiller on top of each of these. It's actually harder to do that with Vivitrol because the blockade is so complete. Can be done, but takes much more management. Now, which patient is suited to these drugs? And one way you could just sort of loosely conceptualize this is think about patients of different motivation going from very low motivation to very high motivation. Well, since Vivitrol requires that you detox first, that requires a certain amount of motivation, higher motivation probably than Suboxone. There might be a patient who says, well, I want to feel a little bit of my opioid each day. If I've got to give up heroin, and that high that I crave, I want to at least feel that I'm getting something. So that patient might have less motivation for stopping opioids completely, and might be best suited to start on methadone because at least they will feel it each day that they take it, and Suboxone less so. You could also think in terms of stability. The patient who has a chaotic life and doesn't even wake up on a regular basis day to day might be best suited to methadone because they have to go to a clinic every day, usually in the morning, and they're withdrawing from methadone, so they're going to wake up and they're going to feel like they want to come in and get that methadone. So low stability, low motivation patients might do best with methadone. If the patient has more stability and can come into a medically oriented office, wants to feel some drug reward, but not very much, they just want to know that they're taking something that's going to help them, and they can show up week to week or month to month after they stabilize, that higher motivation, higher stability patient might be better suited for Suboxone. So this is sort of a way we can think of who's right for which drug. The indications that the FDA has approved gives us a little bit of guidance, but not a lot. Both methadone and Suboxone, or buprenorphine, are for the maintenance treatment of opioid addiction. The oral naltrexone, the LE pill, is not very effective in most patients unless they're closely monitored and sanctioned. So we're not going to talk about that. And Vivitrol has a slightly different indication, which is actually for preventing relapse to opioid dependence. But it has to be following opioid detox because the patient can't be on any opioids at all when they start. Buprenorphine is administered every single day, but it can be prescribed daily in the beginning, and then stabilizing the patient. It can be prescribed weekly, and then after the patient stabilizes further, they can actually come back once a month for a refill. It's accessible if the practice has licensed physicians who are DEA registered, and they have to qualify and obtain a waiver or a nurse practitioner or PA. Any pharmacy can fill a buprenorphine prescription. Occasionally you'll find some that don't want to bother with it, they're afraid of addicts, but any pharmacy is eligible to do this. The pharmacy doesn't need any specific licensing to stock and release buprenorphine. The sites for patient treatment are going to be different. Methadone clinics have to assure that the patient has withdrawal, has 12 months of prior use of opioids, regulates the doses pretty closely. Patients have to be greater than 18. Take-homes are limited and under very specific criteria. And treatment services have to be on the premises and are required for a methadone clinic. Buprenorphine, they don't have those regulatory restrictions. So the patient just has to have DSM-4 or DSM-5 opioid dependence disorder. It doesn't matter how long. It could be a young person who's had maybe only 6 months of use. They wouldn't qualify for methadone, but they can for buprenorphine. The prescribing provider sets the dose, can take it up and take it down. They don't need to follow any rigid dose regulations like the methadone clinics. You can be a little younger and get buprenorphine. And you have to have services available, but that could be done through referral. So buprenorphine is clearly a more accessible and less regulated medication. Now, how many people are getting these medicines? Well, in 2014, 1.8 million people got either methadone or office-based opioid treatment. That's buprenorphine. And it's risen dramatically. So methadone has gone up quite a bit from 2004 to 2014, from 241,000 people in the country to 336,000 people in the country. And that's like a 50% increase. That's okay. Buprenorphine, however, has just grown exponentially to the point of 1.5 million people getting it in 2014. And we have some 30,000 physicians who have the waiver approved to be able to use buprenorphine, but only a third of them are certified for going beyond 30 patients. So even with all this access, it's still not enough to address an opioid epidemic. And the average patient, and this is just one study in a primary care buprenorphine treatment environment, the average patient is only staying in treatment 3 to 6 months. Here, 60% almost stayed in treatment in this research study. And the patients who had a positive urine already in their first week, they dropped out like flies. The vast majority of them were gone within 70 days. The patients who did not start using in that first week, they had a much better retention rate. So there are early indicators of whether a patient is going to do okay on this medicine, and we should be looking for those. In HIV-positive patients, a little bit better retention in this study. And these are small studies. I'm showing you it first. I'll show you some larger studies later. But here, 2/3 stayed for 6 months of treatment, which is, you know, it's not as good as we'd like it to be, but it's not terrible. It's clearly having a beneficial effect. The rate of people who are turning in negative urine samples, that is free of any sign of opiates or cocaine, benefits on buprenorphine. So yes, the percentage of opioid-free urines goes up for opioids. That's exactly why we're prescribing the buprenorphine. But it's actually improving for cocaine too. So it's not necessarily the case that people will just substitute a different kind of drug if the buprenorphine is stabilizing their opioid use. And that's a good thing. In fact, patients say, "Doc, I feel normal" when they're stabilized on Bup. I wake up not sick, which they really appreciate. I have my life back. So it legitimizes the treatment of the patient. Patients can maintain a treatment plan. And if there's someone who doesn't need daily contact, they could be a good candidate for Bup. If they have structure in their life, some sober supports, and are able to go day to day without freaking out with the stress in their life, they can be benefited by buprenorphine. Pregnant women can benefit from buprenorphine. They can actually sustain their obstetric care. They can deliver healthy babies. And I'll talk a little bit about pregnancy later. We'll have another webinar on special populations later in the coming year where I'll go into more depth on that. And the patient who wants to still feel something, that they're getting something for their opioid addiction, they want to feel it working day to day, but not as much as with methadone, they might be a good candidate for buprenorphine. Of course, if they're going to need ongoing chronic opioid pain medicine, they may not be a good candidate for buprenorphine because it's harder to treat pain on top of buprenorphine, although it can certainly be done. It just takes a little bit of adjustment. If the patient is using benzos or barbiturates, they may not be a good candidate for buprenorphine unless they are willing to stop using those sedatives as well. The patient who is an actively alcohol drinking or abusing dependent patient may also be at greater risk of toxicity when they combine that on top of buprenorphine. If they have a lot of psychiatric comorbidity that really disrupts their life, methadone may be the better choice. If they've had many prior treatments with methadone and they keep relapsing, methadone may still be the better choice for that patient. So avoiding alcohol and sedatives is important. If the patient has a cardiac risk, particularly the conduction defect called prolonged QTC wave, they may not be eligible for methadone, and buprenorphine may be okay for them. And it's good in a patient who can establish a daily schedule and a routine and has some supports, can come back week to week without serious risks intervening. And these guidelines are from the ASAM National Practice Guideline for Medications in Opioid Use Disorder, which just came out about 1.5 years ago. So in trying to match patients to treatment, there isn't one best approach. In fact, we just had 2 studies come out in the last 6 weeks, one from Norway and a much bigger one here in the U.S. from the NIDA Clinical Trial Network. And it showed that agonists like buprenorphine or antagonists like Vivitrol, one is not necessarily better than the other. The question is, which is better for whom? The one thing that is clear is that a program that only wants to give one kind of care, that's not good care, because patients need to be able to choose from these different options. They need integrated care. To get the patient onto buprenorphine, they have to be in a little bit of withdrawal, mild to moderate withdrawal. And when the patient finishes buprenorphine, they have to be withdrawn. So we need to know a little bit about withdrawal management or detox in considering buprenorphine. And of course, if the patient is going to switch from buprenorphine to Vivitrol, we have to withdraw them. But as I said initially, withdrawal management alone, detox alone, and having the patient leave after that, that's not treatment. It's medical stabilization, but it's not addiction treatment. Opioid withdrawal management with methadone is possible. It can be done as an inpatient or in a methadone clinic. You can't do it as an outpatient, though. You can't prescribe it from your office. So if we're going to start buprenorphine and we want to avoid precipitating acute withdrawal, which is very uncomfortable, we have to ask the patient to come back the next day. And they can come in the morning, but they have to be in mild to moderate withdrawal so that when you give them the buprenorphine, they'll feel that relief and the craving will subside and they'll be comfortable starting their buprenorphine. And there are ways to accelerate this. There's actually a way to accelerate buprenorphine discontinuation to start Vivitrol, and it's called combining buprenorphine with low-dose naltrexone. I'm not going to focus on that today. That's for another lecture. Clonidine, although it's not FDA approved for withdrawal, it's actually quite beneficial. It reduces the blood pressure, the heart rate elevations, and it has to be used carefully because it can cause some low blood pressure or orthostatic blood pressure when the patient stands up quickly, and that can make them dizzy. There's another way to do that with a transdermal clonidine patch, and that tends to start working slowly, so the patient may require an additional PO clonidine, at least for the first day. So there are a number of ways to manage withdrawal. The one point I do want to stress is that ultra-rapid opioid detox methods under anesthesia, called OUD, actually has a risk of high mortality. That is not an acceptable or approved approach to treating withdrawal. I'm going to go through the starting and stabilizing of buprenorphine, and then we'll take a break. So starting buprenorphine, the patient arrives in mild withdrawal. Now, if you're using the clinical opioid withdrawal scale, the CALS, a score of 6 to 12 is a good score for giving that first buprenorphine dose. And I'll show you that instrument shortly, too. When you give the pill, the tablet, it's not a pill to be swallowed, because if it's swallowed, it'll be digested in the stomach and inactivated. So the patient won't get any benefit at all. Instead, they put it under their tongue, or there is also a film version that the patient can put in their cheek, on the inside of their cheek. But that means you have to keep those things in the patient's mouth for quite a few minutes to allow the medicine to be absorbed into the lining of the mouth or tongue. And that's how it gets into the bloodstream. So it's a little different from giving a pill. And the dose, starting with buprenorphine, and if you combine it with the buprenorphine with naloxone combination, Suboxone, you start with 2 to 4 milligrams for the first dose, and you observe the patient 30 minutes later or an hour later, and you see how they're doing. And if you're using the film, the Suboxone film is the same doses as the Suboxone sublingual tabs. There's a slight difference with Buprenorphine, which I'll mention later. You reassess at 30 to 60 minutes, and if the patient is still uncomfortable or craving, then you add another 2 to 4 milligrams and observe again for 30 to 60 minutes. Now, you might get up to 4, 6, even 8 milligrams on that first day. And then the next day, the patient comes in, preferably in the morning, and you're going to give them a single dose that is the equal to everything they got that first day. So if the first day they got 6 milligrams, the second day in the morning, you give them 6 milligrams. If it was 8 milligrams, you can go up to 8 milligrams the second day too. And for each of the next days of the week, you're going to give that total daily dose in the morning. You want to maintain contact with them by phone. If they're not doing well, you can give them an extra 2 milligrams or extra 4 milligrams. And you really don't want to get above 16 milligrams sublingually a day during that week. Some people actually do this entirely at the patient's home, but that's really only recommended if this is a patient who's already been started on buprenorphine a year ago or past years or months and is restarting and knows, has the experience of knowing how to do that. Otherwise, you really want to be seeing the patient for a daily visit each day for the first few days. Here's the COWS scale, Clinical Opioid Withdrawal Score, COWS. And you'll see it measures pulse rate, and it's very easy for a nurse or PA to do this. And if it's 80 or below, the score is a 0. If it's more than 120 beats per minute, it's a score of 4. Then you have to rate other physical signs of autonomic arousal, sweating, restlessness, pupil size, bone or joint aches. Now, this is not if the patient, fell off their bike yesterday and they have one, or you have to say specifically bone or joint aches due to withdrawal. You're measuring how much runny nose or tearing they have from their eyes. And again, if they have a cold or an allergy, you want to know that because that's not what we're scoring here. Stomach, tremor, yawning, anxiety, goose flesh. And then you sum all of these scores up. And if the patient is above a 6 to 12, they're at a good point for getting their first buprenorphine dose. If the patient has come in with a naloxone reversal of an overdose, there is a high risk that that patient, if they're just sent out of the ER again, there's a high risk that that patient is going to overdose again and die. In fact, if they get buprenorphine or methadone in the context of that emergency room visit in the acute setting, and they're started on maintenance, there's a 50% reduction in the risk of a fatal overdose again. So this is a really important time frame to be taking action. And setting up a program to do this effectively can really be life-saving. Overdose survivors are open to treatment when they've been reversed, and it's a short window of opportunity. We don't want them going out and rethinking, well, but maybe I could score some more dope and I can get high, and, I want to forget about what just happened to me. So we've got to take advantage of that. And patients who've previously been on methadone or a long-acting opioid, there is a little bit of a problem with the combination of buprenorphine and naloxone, because the naloxone can be, a little bit of it can be absorbed and can provoke withdrawal. So this is even more likely with the Buprenorphine film, which has a higher bioavailability. So with the methadone patient who's switching, it may be advantageous for initiation to switch them first to Subutex, the buprenorphine monotherapy without the naloxone, and then after a week or two, switching them to Suboxone. Switching from methadone maintenance treatment to buprenorphine might be the right thing to do if the patient is having side effects that they don't like on methadone. If they aren't establishing stability with methadone, maybe the methadone is having too much of a perceptible effect. Maybe it's not euphoria, but it could be that they feel it too much and they're too reinforced on it. Buprenorphine might produce less of that reinforcement. But if you're switching from methadone to buprenorphine, then it could be just because the patient has done very well and wants to stop coming to their methadone clinic or wants to try a partial agonist. You have to get them down to low doses of methadone each day. So that may take many, many weeks or months. And a low dose of methadone is 20 milligrams or so per day. Could be 30, could be up to 40, but once you get up to 40, that's a lot to just switch to buprenorphine. And again, you want the patient to come in feeling their withdrawal before you switch them to that first dose of buprenorphine, even if they're coming off of methadone low dose. So we've initiated the buprenorphine, however we had to do it, and now the patient is getting a dose less than 16 milligrams or up to it. And we do not want to be going above 24 milligrams a day. So the patient can be getting this usually once a day. If they have chronic pain and they're on a higher dose of buprenorphine to treat chronic pain, sometimes we'll give them twice a day or even 3 times a day doses. But that's not common, and there's really not a good reason to do that unless they have a pain condition that needs opioids. So we should be seeing the patient for the first month and a half. We should be seeing them once a week, at least, minimum. If the patient comes in and says, oh, I lost my prescription, or my pills were stolen, or they fell down the toilet, or the dog ate them, that's an indication of relapse and diversion. We should not be replacing them. There are rare cases where, all right, you'll agree to replace them, maybe based on corroboration from a partner. Of course, it can't be a partner who's also in opioid use disorder. The patient should be told that this will never be done again. And if the patient comes in with a series of these kinds of requests, it's a sign that their visits should be more frequent or their level of care should be escalated. So always remember to reassess the patient who's coming in with these kinds of requests and consider increasing their level of care. Also, there have been many overdose and death events with children who got into parents' buprenorphine. It's supposed to be less likely with the strips, but it can happen. So buprenorphine stabilization is that next phase. It's got to be done with counseling and attention to diversion, which should include drug testing in the beginning once or twice a week. After a number of weeks of stability, it can go to once a week and then to every other week. You should test for buprenorphine specifically. I'll mention later how to do that. And anybody who's prescribing buprenorphine should be checking their state's prescription drug monitoring program, their PDMP. Okay, let's take a break for 5 minutes, and we will come back at 1:15 and finish the next section of this webinar.
Thank you. So as Dr. Gastfriend has said, we will take a 5-minute break and come back at 2:15. Dr. Gastfriend, can you hear me?
Yes, I can.
I'm going to send you just a couple of items in your chat panel.
Okay, I got it open. Okay, welcome back. We're ready to resume the webinar. And I want to take a couple questions that have come through. So don't hesitate to type into your chat or Q&A boxes any questions that come up. First question is a patient who wants to switch from methadone to Suboxone. What level of milligram dosage should the patient get down to of the methadone before they safely can switch to Suboxone? And as I said, I think 20 milligrams a day of methadone is the ideal point at which to switch. But again, that can take weeks or months. And you know, if the patient knows they can switch and it's in the cards, then there shouldn't be a rush to do this. The gradual taper of methadone is always the more effective way to go. And then when it's time to do the switch, the patient should have an appointment and be told not to take methadone the day before so that they're in mild withdrawal. And, you know, you could take methadone on the last day and then come in the next day in the afternoon. By that point, the patient may be in mild withdrawal. If they're not in mild withdrawal, they should wait longer until they are in mild withdrawal. Another question was about Vivitrol versus buprenorphine. What are the pros and cons? And just briefly, patients on Vivitrol do have a reduction in craving, like they have a reduction in craving with buprenorphine. They are stabilized for a month at a time. So they have the convenience of only having to come in a month at a time for the medical visit. Vivitrol is not a controlled substance, so it won't show up in their urine, and it won't be a problem if they go for drug testing, if they drive a DOT-regulated 18-wheeler across the country and get random drug tests, or if they're on a sports team, or if they're a pilot. So, you know, Vivitrol has some advantages there. There are some patients who prefer not to be on an opioid of any kind, even a partial agonist like buprenorphine, and they may want to be on Vivitrol. Sometimes parents don't want their 20-year-old with opioid use disorder to be on a medicine that will, you know, they'll be on for years, like buprenorphine. And in that case, they may prefer the idea of Vivitrol. The important thing is you want to make sure that the patient feels that way too. Courts are finally becoming amenable to medication-assisted treatment. Sheriffs releasing people from jails or from state prisons are finally becoming amenable to medication-assisted treatment, but they're not thrilled yet about buprenorphine. So they may be okay with Vivitrol if they understand what it is, and that may be a way to get them started on the path of letting doctors be doctors and use their medical judgment to find the right medicine for the right patient. You know, is that fair? Is that right? No. Is it the way it is? Well, a lot of the time it is. So that's just, you know, a brief listing of some of the differences. When we talk about Vivitrol, that'll be another webinar, by the way, in the new year, and I hope you'll be able to listen in on that. We'll go into more detail. We have some good data on that now because now there have been many hundreds of patients in head-to-head trials, both in Norway and throughout the United States, and so we have good data recently released on the comparison between these two. But the summary of both of these studies is that both of them work. If the patient takes buprenorphine or takes Vivitrol, they do pretty similarly, pretty equally well. The differences are it's harder to start Vivitrol. It's harder to get off of buprenorphine. So, you know, one is the fly now, pay later plan. That's the buprenorphine, and the other is the pay now, fly later plan. That's the Vivitrol. So, you know, they're different, and it's good to have different treatments. So let's continue now. Oh, and by the way, I've been asked whether I've authored any books on this subject. The answer is no. I have not written any books on the subject of buprenorphine or M18. But thanks for the suggestion. Okay, so we're going to talk about buprenorphine maintenance. So it's been a month or 6 weeks, and the patient is on a stable dose of 4, 8, 12, 16, maybe as much as 24 milligrams, and we haven't had to change it because the patient says they're doing better and they are glad and they're stabilized. So now what we want to do is establish a routine, and we've dealt with ASAM dimension 1, which is the withdrawal dimension, but now we want to make sure the medical dimension, the psych stuff is getting treated, and so forth. The social stuff is getting addressed, the patient's motivation and stage of change is, and the whole point is this is a foundation. This is the concrete slab on which we want to build a house of recovery. So in the beginning, we're having the patient visit at least every week, and after 4 to 6 weeks with good stable attendance and medication, we can switch that to every other week to every month. Each decrease in the frequency of visits should be based on what the team is observing as a group, okay? So you want all the input from all the members of the team, and actually preferably also a significant other if you can. Drug testing should still be continuing. If there are any follow-up labs, if the patient had elevated LFTs, liver function tests, or a reason to get those, you want to make sure you're following them up. Sometimes those will be repeated 3 months later. If there's a problem with alcohol, you may want to be doing breathalyzer testing. And if the patient needs to treat alcohol use disorder at the same time, there are medications for that. The thing is, you can't use naltrexone to treat alcohol dependence if the patient has that on top of their opioid dependence. Because if they're on buprenorphine or Suboxone, the naltrexone will throw them right into withdrawal. So you don't want to use naltrexone in combination with buprenorphine. The drug testing should be done at least at every visit, and you have to do it right. There's no point in doing drug testing if the patient can easily cheat it. It doesn't help the patient. And if you don't think patients will try to cheat, you're not respecting the disease. This is a disease that corrupts the brain's sense of self-preservation. So if the patient's brain isn't operating to preserve their own survival, they're definitely not going to be offering you an easy path to taking care of them, and you have to have a healthy suspicion of the disease. So we tell the patients, leave your coats and bags in the waiting room or in the office, but not where you're going to the bathroom. No coats and bags, no handbags into the bathroom. Don't wash your hands until you hand off the urine, and you put that in a biohazard bag so nobody's touching urine. And the reason is you don't want the patient to be taking their cup of urine to the sink to add a little water to it and try and dilute out any drugs they may have put in there when they peed. You also tell them no toilet flushing until the urine is handed off to the assistant who's collecting the collecting the urine. And the reason is, again, toilet flushing means water is going into the bowl. That water could be put into the collection cup, or the patient could be flushing some of their urine down the toilet and giving you a diluted urine. If there's any question that this urine may be adulterated, you have to repeat the urine later that day. So give the patient a chance to drink a couple glasses of water and wait an hour, and then before they leave, they have to be retested. And it's obviously ideal to do random and observed urines where you're watching the patient pee, but that has to be done by a staff member of the same sex, and it's rarely done. Another way to do observed drug testing is oral swabs. Oral saliva testing actually is widely available and is quite good. There are 12-panel tests detect buprenorphine with just a swab of a Q-tip in the mouth. And so that can be done for a patient for whom the concern about adulteration is a risk. If there is a chain of custody required, there are labs in many parts of the state that handle it this way. It may be that a patient who is playing with their urines really just needs to be sent to a higher level of care for more intensive management of their addiction. There are ways to check the validity of urine. There are cups that have urine temperature strips on them, or pH strips, that detect if the patient has diluted their urine. And you have to know what you're using, read the instructions, and stick with a single device so that everybody in the clinic is comfortable with it and knows it well. If the patient is relapsing, how would you know? Well, if you do a urine test and there's no buprenorphine showing up in the urine, then you know the patient isn't taking the pills that are being prescribed or the strips that are being prescribed. So that means you've got a patient who's either storing up or diverting, and now you've got trouble. So you have to address that relapse. If the patient is coming in with ongoing benzo or barbiturate or other CNS depressants or using stimulants or alcohol, the depressants and alcohol are actually risks for overdose and death. So you have an obligation to address that just from a medical legal perspective. But more importantly, that's relapse. And the patient, even if they're not going to overdose and die from it, if they're using stimulants, that is not a stable patient. If you see the patient with signs of impairment or sedation, or they're not taking their other medications or taking them excessively, not going to visits for their medical care or psychiatric care, if the patient is hospitalized due to drug use, and you are able to learn about that, all of these are signs of relapse that require a modification of the treatment plan. Now, do we just cut off the buprenorphine because the patient has come in with benzos in their urine? No. We're using buprenorphine as a harm reduction model. It's not a punitive treatment, and we shouldn't have automatic discharges or administrative discharges. But we should revise the treatment plan, and we should say, look, you know, we care about you, we care about your life, you should too, even though the disease makes it hard to do that. And the right treatment for you is maybe it's day treatment, maybe it's residential, maybe it's twice a week or 3 times a week visits. So that adjustment is really important. And if the patient continues their use of these substances despite more frequent visits, then you have to go to an elevated level of care. We're going to talk more about withdrawal severity now and discontinuation because patients don't stay on these medicines forever. Now, if they come off of heroin, that's a very rapid onset and a very rapid offset. So the symptom severity is great when people come off of heroin, and it's fairly brief. Within 5 days or so, the intolerable symptoms of heroin withdrawal are pretty much waning. If the patient has been on buprenorphine, they have a slower withdrawal. The withdrawal can actually be weeks or months, and it may be not a severe withdrawal, but it can be an aggravating withdrawal. So in this blue band, you see the threshold of tolerability. At no point will the patient say, I can't stand this. However, if it's chronic, lasting weeks, and here you can see it peaks at a fairly low level after over 2 weeks, but it can go on 3 weeks, 4 weeks. It's the chronicity that sometimes causes people to relapse. So it's a little bit like patients saying, you know, I wish I had just ripped the Band-Aid off all at once and gotten it over with. Maybe you scream for an instant, but then you say, it's all right, that's okay. And the difference is peeling it off, you know, millimeter by millimeter by millimeter and pulling every little hair out. So that's very aggravating and can provoke relapse, which is why we either have to do opioid withdrawal like the buprenorphine slowly, or we have to have a medically managed approach. So discontinuation. There are several points that we have to note. One is that we have to warn patients. If you discontinue agonist therapy like methadone or buprenorphine, and then after some period of time you go out and use opioids like heroin, there is a risk of overdose. You have retained some tolerance, but over time you'll lose that. And people do discontinue buprenorphine. In fact, buprenorphine discontinuation is regular, it's frequent, and it's problematic. Now, there was a major study. Dr. Roger Weiss, a good friend of mine from McLean Hospital, led the study for the National Institute on Drug Abuse. And they published this in the Archives of General Psychiatry in 2012. They treated hundreds of buprenorphine patients who were prescription pill addicts. They were not heroin addicts, so they weren't the most severe patients. And they treated them with buprenorphine for 3 months. And they tapered them off of buprenorphine over a 1-month period after 3 months. So, you know, they did it. It was a very legitimate, medically appropriate treatment of buprenorphine and discontinuation. The problem is 92% of those patients relapsed to opioid use again within 8 weeks of finishing that 1-month buprenorphine taper. So that is not a good thing. And it means that buprenorphine taper and discontinuation has to be done extremely slowly, or maybe it shouldn't be done. And that means patients have to be educated to stay on buprenorphine for a long period of time. And they should be monitored even after the buprenorphine is finished. It means that when they stop their last buprenorphine dose, they're not done in their treatment. They should be monitored weeks and months, even years after that. Buprenorphine taper should be done over several months at a minimum, and they should remain in their counseling treatment even past the point of discontinuation. Now, there are alternatives to the sublingual tablet. Buprenorphine film, and Suboxone is one of the film brands. So Suboxone film has both buprenorphine and naltrexone in it. I'm sorry, naloxone. And that dosing is the same. If the patient's on, let's say, 12 milligrams of Suboxone, which will have 3 milligrams of naloxone in it, then that's what they should take with the Suboxone strips. Buprenorphine is a little different. It's actually a little bit like tape. So the patient puts the strip in the inside of their cheek, and the tape speeds up the absorption of the medicine through the tissue of their cheek into their bloodstream. And so that increased speed of absorption means that they actually can use a lower dose. So the doses are slightly lower. And you can see here, the Buprenorphine dose of 4.2 milligrams of buprenorphine is equivalent to a Suboxone film dose of 8 milligrams, or Suboxone tablets of 8 milligrams. So those are equivalent. And Buprenorphine, just like the Suboxone strips, have different dosages, different types of strips. One thing is that it's important that with the Buprenorphine strips, the film should be left on the inside of the cheek for 15 to 30 minutes. It'll disappear, actually, it dissolves. Sometimes it leaves a little residue, and sometimes patients just spit that out. But you don't want people swallowing water or peeling it off or throwing it out before 15 to 30 minutes, because then they won't be getting their full dose. The actual medicine comes across in a matter of minutes. It's actually faster with Buprenorphine than with the Suboxone strips, and both of those are probably faster than the tablets that are held sublingually. And the cost is different too. So Buprenorphine is $8 per pill equivalent versus Suboxone, which is about half of that. The final alternative, which is also FDA approved now, is the Buprenorphine subcutaneous implant. These are 4 little rods. The rods look like this. There are 4 of them, and they're placed inside the upper arm. And the surgeon actually, and a family doctor can do this too. Actually, an NP can do this. Puts in an incision with a little bit of anesthesia on the skin, and puts in these 4 little rods, and then puts in a couple stitches on top to close it, and a bandage until it heals. And this produces a 6-month-long release of buprenorphine so that you don't have to take anything by mouth. And there is a whole program to train doctors to do this, and they actually do this in person, a live face-to-face training, not just for the surgical insertion in the beginning of the 6 months, but there's also a surgical procedure where you have to remove these rods at the end of 6 months. You actually cut the skin and pull out the rods and then close it up again with another set of stitches. So the FDA requires that this training be provided, and when it was done in a study with 176 opioid use disorder adults who first were stabilized on sublingual buprenorphine tablets, 84% had no illicit opioid use over the next 6 months, which was comparable to buprenorphine, 79%, in a double-blind study. So it's clearly effective, and that means the patient is definitely getting it for those 6 months and doesn't have to, come in for visits to the prescribing doctor. They should be going to their therapy, but they don't have to see a medical doctor on a regular basis once the implant is healed up. So it's safe and effective. It hasn't been studied under age 16 or over age 65. There can be some reactions, itching, redness, and other, irritability at the implant site. And typical symptoms of withdrawal can occur. Constipation, which can be associated with opioids, can occur. And there are rare cases where the implant has moved or pushed through the skin, but these are rare. And there is still the risk if the patient misuses benzos or sedatives or drinks alcohol excessively that they could overdose because they have buprenorphine in them. So it's not different from the sublingual tabs. And the cost is quite different. There's a $5,000 roughly charge for the 6-month implant, or $820 to $5 a month if you divide it. And that is substantially higher than the sublingual tabs or the film, but remember, the patient is getting the certainty of having 6 months of treatment. So if the patient isn't stabilizing on buprenorphine, even though you set up a schedule to see them more frequently or even sent them maybe to a higher level of care like commercial hospital or day treatment, or if the patient's unhappy from their buprenorphine treatment, maybe they need to be switched from buprenorphine to methadone. But the good news about that is that if the patient is going to be switched from buprenorphine to methadone, then you don't have to delay or wait for withdrawal or anything. You can go from the day before they got buprenorphine to the next day, they can go right on to methadone because you're adding a full mu opioid agonist to the previous partial agonist treatment, and so there's no risk of precipitating any withdrawal. So it's easy to switch from buprenorphine to methadone maintenance treatment. What about switching to Vivitrol, extended release naltrexone? Here, not only do you have to wait a day, you should be waiting multiple days. The reason is buprenorphine is strongly bound to the brain's opioid receptors, but naltrexone is even a stronger binder to the brain's opioid receptors and will knock off the buprenorphine and throw the patient into immediate withdrawal, precipitated withdrawal, which is actually worse than cold turkey. Because cold turkey happens over hours. Precipitated withdrawal with Vivitrol happens within minutes. So it's very uncomfortable, and the patient may reject treatment after that because it's so upsetting. So you can wait 7 to 14 days, and you can do a naloxone challenge and even do an oral partial dose, like half dose naltrexone challenge, because naltrexone, if there is buprenorphine left, naloxone may not knock it off, so you may not know. Naltrexone will. We'll talk about this more in the Vivitrol webinar in a few months. But in any case, you can test to see if the patient is ready to switch from buprenorphine to Vivitrol with a half dose of oral naltrexone, and the patient takes it, swallows it with some water, and then you wait at least a half an hour for them to absorb that and see if they're having any withdrawal. And if not, then they should be ready for their first Vivitrol injection. I mentioned pain, and you can actually treat acute pain by increasing the buprenorphine dose temporarily if the pain is not severe. If the patient has severe acute pain, like from a major surgery, you can use a high-potency opioid like fentanyl. You should monitor the patient if they're going on to fentanyl because there's some risk of affecting their breathing, and an anesthesiologist or anesthetist should be involved. And if they're going to have elective surgery, often surgical teams will decide to discontinue the patient's buprenorphine, but they should be restarted right away afterwards once the need for opioid pain relief is passed. But it's also possible to just continue the buprenorphine straight through. So it's just something that needs to be thoroughly discussed. Pregnancy, I mentioned that it is safe, and it's not just safe, it's also good. It actually stabilizes the pregnancy. The baby will have buprenorphine physical dependence when the baby is born, but that is something that can be easily managed in the neonatal ICU. And it takes a certain amount of medical intervention, but compared to methadone, the baby on buprenorphine, the neonatal abstinence syndrome, that's what NAS means, needs less treatment, less medicine, less morphine, and shorter hospitalization. So it's actually perhaps a better treatment for an opioid-dependent mother in terms of the baby's outcome, although retention might be better for the mother with methadone. So you have to balance those two needs. You don't use the naloxone preparation in pregnancy because the naloxone can also cross the placenta. And buprenorphine is excreted in breast milk, so bottle feeding may be recommended for the newborn. Now, in young people, so moving off of pregnancy to another special population, medication retention is seemingly quite better than retaining people in counseling, young people in counseling, without medication. The amount of time is significantly longer if the patient is on a medication. It doesn't matter whether it's Vivitrol or buprenorphine. If you look at retention and then if they drop out, the amount of time they're retained. Subsequently, very similar with either of these medicines compared to if people are only getting counseling without medication. So even in young people, the use of medication is superior to counseling alone. One of the nice things about buprenorphine is that the patient feels normal when they're on it. They don't have an altered cognitive functioning, at least in no overt way. There's also no organ damage. It has not been confirmed that there's any liver problem. Heart effects on their conduction is not found. And their risk, obviously, as I said, is lower for respiratory depression and overdose unless they're using benzos or sedatives or alcohol combination. We don't see a lot of clinical interactions with other drugs. And if the patient has hepatic impairment, that could reduce their naloxone clearance, but it'll do that more than the buprenorphine clearance. So even with mild to moderate hepatic impairment, buprenorphine can be quite safe. Benzodiazepines and sedative hypnotics are common in the opioid use population, and 30% or more of opioid-related deaths involve benzos. So concurrent opioid and benzo use is a serious problem, and you really have to be doing urines to check for this because it's a disease. The patient's in denial with themselves, so of course they'll be in denial with you. And in the majority of these cases, one of these drugs was prescribed. The benzo might be prescribed. It might be prescribed by a doctor whom you don't even know is treating the patient. Another reason to check the PDMP, the Prescription Drug Monitoring Program in the state. You know, buprenorphine is stigmatized. That is wrong. You know, people say it's just substituting one drug for another. That's not true. It's substituting a much, much better drug in which the patient can actually heal for an illicit drug that is, you know, killing the patient. So we really want to try and overcome those stigmatized attitudes. We've already talked about the limitations of the number of patients that can be treated, but generally, these laws are making it more accessible, and we should take advantage of the opportunity to provide access. Now, we are seeing that the growth in buprenorphine use is happening more in doctors who are going above the previous cap, the previous limit of patient numbers from 30 to 100 and beyond 100. That is okay, but we really need to see more doctors treating their first 30 patients, or NPs or PAs, because we need more distribution geographically of buprenorphine, not more concentration in certain geographic areas like the cities. Buprenorphine is diverted. It's the third most diverted prescription opioid according to the DEA. And there are people who are in opioid treatment who are diverting buprenorphine to get high. Now, how does that happen? Well, if you haven't been on buprenorphine and you get diverted buprenorphine and use it, you will get high. You won't get as high as if you use heroin, but you still feel high. It's only if you're on buprenorphine consistently that you will not feel any euphoria. So diversion is still a problem. And the retention on buprenorphine is not nearly long enough. One study said 66 days is the average retention. That's only 2 months. Another study, which I was involved in, from 7,000 insurance records, showed 69 days, very similar. The adolescent study in Baltimore showed 9.6 weeks. That's almost the same as these. And as I said, if 3 months of buprenorphine followed by a month of taper leads to 92% of buprenorphine patients relapsing, then these short time frames of treatment are not nearly enough. So we have to focus on improving this persistency. In France, they were one of the first countries to do a broad expansion of buprenorphine throughout the country. And for a while, they saw a reduction in the rate of opioid deaths, which was great. But by 2011, they were having an increase in opioid deaths, and half of their opioid deaths were related to buprenorphine, more than heroin. So they then imposed more controls on how buprenorphine was used. Now, America has more controls than France, so we may be doing a better job of protecting patients. In Baltimore, they were one of the first big systems to introduce buprenorphine on a harm reduction basis, but they didn't really stem the tide of heroin overdose deaths, even though they had buprenorphine on demand and methadone on demand. So it doesn't necessarily prevent the epidemic, and I'm not sure that we should expect it to either. That might be a tall order. Australia found that mortality did decrease with buprenorphine, but particularly in the first 4 weeks. After 4 weeks, it wasn't making as much of a difference, and methadone was doing similarly. But in the first 4 weeks, buprenorphine actually did better. Now, what's the advantage of buprenorphine versus methadone? Well, one advantage is that methadone has more delayed reaction time and more impact on decreasing verbal memory than buprenorphine, which has more of an effect than people who are on placebo or controls. Working memory is a little bit diminished with methadone compared to buprenorphine, and verbal memory is diminished, and visual memory is diminished, and driving reaction time is diminished, more with methadone than with buprenorphine. So that ceiling effect of buprenorphine is a good thing in a number of ways. However, in treatment retention, a full dose of methadone here called high-dose methadone, is better at retaining patients in treatment than standard dosing of buprenorphine. So retention could be better for methadone, and we've seen this again and again. Flexible dosing of methadone versus buprenorphine doses up to 16 milligrams, methadone has better retention. But still, there are people who don't tolerate methadone or who don't want to be on it anymore or who've stabilized on it and would like to go to something that has less of an effect, and buprenorphine has those advantages. This is just a summary of a whole bunch of studies comparing retention on buprenorphine versus methadone. If these dots are on the left side of this vertical line, then it favors methadone for better retention. And you see that most of them are on the left side of the line. So that's overall a consistent finding. We don't need more studies to see this. There is, as I said, diversion of these drugs. Now, if you look at the average number of causes of abuse estimated by addiction treatment experts, obviously drugs like oxycodone, OxyContin, are much higher than methadone or buprenorphine. And methadone diversion seems to be higher than buprenorphine. But this is actually an old slide. This is 12 years old. And we get condemned by society for this diversion, even though it's impossible to prevent 100% behavior like diversion. So here's the jury saying to the judge, we find that all of us as a society are to blame, but only the defendant is guilty. So unfortunately, there's plenty of blame that goes around. The New York Times attacked buprenorphine in April of this year with a big Sunday New York Times article in the magazine, a so-called expose. And the title was Addicted to Addiction Treatment, which is really unfair because the physical dependence of buprenorphine is not an addiction. It's nothing more than physical dependence. It actually treats addiction. So you can't always believe what you read in the newspaper, and some people say that a lot these days. But in this case, it's a shame that headlines are taking our treatments to task. I want to skip ahead just to a case because there are many other considerations here. Cost is a consideration, but buprenorphine's cost, when you take into account all of the costs of healthcare, buprenorphine's cost can actually be lower than methadone, even though methadone is generic. And that's because people are having less hospitalization or emergencies. So I'm looking for your questions if there are any. We can put them up on the screen, or somebody can read them to me. If not, I'll ask you a question. Well, here's a question. How do we determine the necessary buprenorphine dose? And the answer is it's difficult. The patient says subjectively, well, I'm not feeling like it's holding me, and still have some, I feel a little bit of craving, withdrawal, and not sleeping well. So we need the patient self-report, but then we have to balance that by objectively detecting their function. And maybe we need a collateral, a family member. And then we need drug testing to see if they're actually taking all of their buprenorphine. Are there head-to-head trials of buprenorphine versus Vivitrol? And the answer is, well, there are insurance claims. There's a retrospective claims analysis that shows that people on buprenorphine do have good outcomes, much better than if they're untreated with medication. And then we have these two trials published just this year, last 6 weeks or so, the Norwegian head-to-head random controlled trial, Vivitrol versus buprenorphine. And actually, the NIDA Clinical Trial Network study has been published now in Lancet just last month. So we know that these drugs can have fairly equivalent outcomes. The important thing is that we use them, that we choose the right patient, and give patients a chance. If they don't do well on one, we should just switch to the other. Like we would do with a hypertension drug or an antidepressant drug. We would never say, well, which antidepressant is the best antidepressant? There isn't an answer to that question. We shouldn't be doing that in addiction either. So I will finish up there, and I want to thank you for your attendance. There are almost 200 of you on this call, and I want to congratulate Florida for doing this large-scale initiative to address the epidemic, and thank you all for your participation in helping our patients.
Dr. Gastfriend, we had one additional question. Would you like for me to pose that to you?
Yes, please.
Okay, and then we will wrap up. Let me make sure this is the final one. Okay, it looks like we might have two, if that's all right.
Sure.
All right, this one says, and there's an acronym here. I'm not sure what, well, I think you'll know what this is. You referred to DOC drug testing. Is that Department of Correction?
Yes.
Okay. You referred to DOC drug testing. When an offender is receiving medication as treatment, what are the substances to be avoided in a test?
Okay. First of all, if you're treating someone who's under parole or probation monitoring, you definitely have to communicate with their parole or probation officer so that there's agreement that this medication is okay to be used. If you do a NIDA 12-panel test, that will detect buprenorphine. And if the patient is prescribed it, they should show that they've got buprenorphine in their system. If they don't have buprenorphine positive on such a test, then they actually are in violation of the treatment. They're not adherent to the treatment. If they have other drugs like stimulants or sedatives or whatever else is being tested in the 12 panel, then it's a problem. Of course, the patient should not be on both methadone and buprenorphine. If it comes up that they're on methadone and buprenorphine in their urine test, then that's a sign that they are obtaining diverted methadone and abusing it.
Thank you, Doctor. And our last question is this. What recommendations do you have with regard to addressing the stigma in 12-step programs with respect to MAT?
Oh, that's a great question. I'm so glad you got that in. So a good way to start is to educate patients that the big book, the founders of AA, were not opposed to medication if it was medically sound treatment. So that's important. Number two, it's a good thing to form an AA or NA meeting in your program and host it where you know there will be patients who are stable and succeeding on MAT and sharing the meeting. So if they're organizing the meeting and establishing a tone that we're not taking one another's inventory and we're not going to stigmatize people for participating in good health care, then you've got at least a home base for people, and that's really important to provide them. If you have recovery coaches or other recovery support service people who can assist the patient who is on MAT so that when they go to meetings, if they get any flack, they can, have a supportive person from the community of recovery who says, hey, listen, that's not the thing you should be paying attention to. So, there are at least, several different ways you can help people cope with this. And they don't need to talk about their MAT when they're starting out in the meeting. And once they're established and people have some trust and confidence in their recovery, if they acknowledge it to their sponsor and then to a small but growing circle of friends, then they can influence meetings to be, non-stigmatizing to MIT.
Dr. Gastfriend, thank you. And if you're ready, I'm going to resume control of the presentation for a few concluding remarks.
Sure.
I'd like to remind all of our participants today that when you exit the event, when I close it or when you exit the event, your browser is going to take you to the evaluation form that I mentioned that's on the FATA website. And if you have any trouble with accessing that evaluation, not to worry, we will be sending a follow-up thank you email to you, and that will also have a link to that evaluation form. So you can always watch for that as well. So be sure to complete the evaluation. And do remember, we're going to be emailing your certificates of attendance and a PDF version of today's presentation within 5 business days. And really, finally, we really want to thank Dr. Gastfriend. Thank you so much for joining us today. And as usual, we have a very well-attended webinar today for your presentation, and we just appreciate you very much. And
thanks so much.
Of course, and then we want to especially thank the Florida Department of Children and Families, the Office of Substance Abuse and Mental Health for funding today's webinar. So thank you, and we will speak again to the participants on our next webinar. Thank you, and you guys all have a great day. Bye-bye.